speaking on acute coronary syndrome. So we have a session of just around 1 hour. So he is an MBBS gold medalist, now MD medicine gold medal. Now he is consultant physician at Siliguri, Maharaja Agrosim Hospital and Hospital Clinic. He is an ex-faculty of North Bengal Medical College, honorary secretary of IM Siliguri West Bengal branch, honorary secretary of Clinical Cardio-Diabetic West Bengal, immediate past chairman ISCCM Siliguri, and EC member API West Bengal branch, ISCM West Bengal branch, and editorial board member Indian Diabetes Education of RSSDI. So he will be talking on the topic the acute coronary syndrome patient, which is a very common disease we encounter daily in our practice. So now I welcome Dr. Sankha to kindly start his lesson and highlighting the people regarding this topic. Thank you.
Thank you, Dr. Shil. May I start?
Start.
Thank you, sir, for your kind introduction, and thanks to ISCCM for giving me this opportunity. Dr. Sankha Sen, as a consultant physician, I want to discuss on this particular topic, which is a very common thing in emergency patients in our ICUs. So next slide, ma'am. Next one. So because I can't move my slides, when I finish my reading my slides, you please go on changing the slides, ma'am. Huh? Okay, thank you. So acute coronary syndrome is a life-threatening condition, and in our aging population, its incidence is likely on the rise. We all know that we see many patients who come with acute coronary syndrome. The treatment aims to ease the symptoms, that is to decrease the symptoms like chest pain and all, and improve the coronary artery blood flow, otherwise we can't reverse it, and also to prevent the complication of acute coronary syndrome. So most important is we need to have an immediate management, which is combined with cardiac rehabilitation and secondary prevention, so that not only the immediate management, along with that we have to prevent it as secondary prevention, which can improve the patient's outcomes and quality of life. Next slide, ma'am. So this diagram shows that there is a blocked blood flow in the coronary artery, and that is the atheroma. The yellow colored one is the cholesterol deposit, which is called atheroma, which lines the coronary artery. And when it gets blocked, it can be myocardial infarction when the 100% occlusion is there, or it is an ischemia, like it occurs in any blood vessel, which is probably not 100% blockage is there. So once it is fully blocked, it is called infarction. And when it is not fully blocked, it is called ischemia. And it can be two types, ST elevation and non-ST elevation MI. Both are acute coronary syndrome, but what is important is we can treat differently for ST elevation MI or non-ST elevation MI. Next, ma'am. So myocardial infarction is an irreversible necrosis of the heart muscle secondary to prolonged ischemia. The previous one. The previous slide, please. Usually there is an imbalance in oxygen supply and demand, and most often it is caused by the plaque rupture with thrombus formation in a coronary vessel, resulting in an acute reduction of blood supply to a portion of the myocardium. So it's very important. When there is a plaque that I showed in the picture, when there is a rupture, it produces a thrombus, that means a clot in the coronary vessel, and there it disrupts the blood supply in a portion of the muscle of the heart, that is the myocardium. So it is called myocardial infarction. Next, ma'am. So 80% to 90% of all acute MI are secondary to thrombus formation. And when the thrombus develops, there is perfusion to the myocardium, distal to the occlusion is halted, resulting in necrosis of the myocardial wall, and that is where the acute myocardial infarction sets in. Next. So acute MI, the process takes time. The cardiac cells, that is the cells in the heart, can withstand ischemic conditions, that is less blood supply, for at least for around maximum of 20 minutes. Before that, after that only the cellular death begins. So the earliest tissue to become ischemic is the subendocardium, that is the innermost layer of the cardiac muscle. Then gradually it progresses. And if the ischemia persists beyond 4 to 6 hours, it becomes necrose. That is, the tissue becomes non-viable. So we need to treat early, because so too early, we recognize the patient is having heart attack or myocardial infarction. We can treat them early. Next, ma'am. So this is a picture. See, one particular area of the heart shown by the arrow has necrosed, and that is the areas of necrosis. That is the white arrow. Next. So it's a life-threatening condition, and that the nurses frequently encounter in the emergency and the intensive care unit. So timely recognition of acute coronary syndrome is necessary for immediate management and to reduce the risk of death, and further cardiac events are very important because the risk of mortality is very high. And here we are discussing this because the nurses have a crucial role in early recognition and administering treatment and helping patients to understand their condition and care. Next. So the overview, we can say that when we suspect an acute coronary syndrome, when the patient comes with symptoms of chest pain, chest discomfort, we need to have a 12-lead ECG. The ECG will tell us if there is whether there is ST elevation MI or a non-ST elevation MI. The ECG we have to read, and the basics of ECG should be known to all of us. And if there is an ST elevation MI, we shouldn't wait. We should do the thrombolysis immediately. And if the opportunity to having the primary PCI, the cath lab facility is available in your hospital, definitely primary PCI is the best option. And if there is non-ST elevation MI, we can't be sure. It can be either unstable angina or non-ST elevation MI. In MI, the TROP-T is quite important because the TROP-T or troponin I, whichever is available in your hospital, if it increases, if it is positive, then it is called non-ST elevation MI. And for there also, the person may need a PCI within 72 hours, and very importantly, as early as possible. But thrombolysis cannot be done in those patients. And in patients with unstable angina, whether troponin T is positive, is not positive, or troponin I is negative, then we need to follow it up with medications. Next. So the nurses have a crucial role in clinical management by helping them understand their condition, they care for them, and promoting the secondary prevention, that is the complications. Next. Next, please. So the facilitating and administering prompt treatment, promoting swift recognition of deterioration, because the blood pressure is coming down, the heart rate is decreasing or even increasing, leading to so the VT, VF, we need to understand, and the recognition is very important. And the holistic care and psychosocial support is also very important, and encouraging patients to engage in healthy secondary prevention behaviors, like what we ask them after discharge. Next. So infarctions, as I said, we said that anterior wall infarction, inferior wall infarction, or lateral wall infarction, it depends on which wall of the heart is damaged. And as I said, there are two types of myocardial infarction, that is ST elevation MI and non-ST elevation MI. Next. And the acute coronary syndrome, which we are discussing today, does not involve only the non-ST elevation MI or the ST elevation MI, but also any form of angina, which can be stable angina, unstable angina, or even certain variant angina, which is quite rare but very important to know. So angina is usually chest pain due to cardiac cause. And when there is chest pain or the chest pain equivalent like chest discomfort, shortness of breath, we need to get an ECG done at the earliest. Next, ma'am. So stable angina, that is the patient is we can differentiate whether stable or unstable. In stable angina, there can be an episodic chest pain lasting 5 to 15 minutes, provoked by exertion and relieved by rest and nitroglycerin. While in unstable angina, there is increased pain and is easily induced. It is increased risk of this particularly going to be having non-ST elevation MI or ST elevation MI. And in these cases, the ECG changes are quite important. And these patients may have T wave abnormality, but usually in unstable angina, unless it has changed to myocardial infarction, The cardiac enzymes are negative, like troponins I and T. Next. So what are the risk factors of acute coronary syndrome? Because there are certain risk factors which we can change by our actions, that is called modifiable risk factors. And there are certain non-modifiable risk factors like the age, elderly patients, gender. As you know, when the protective effect of the hormones, female sex hormones decrease, then the females also have similar, like after menopause, female have a higher risk compared to their premenopausal state. Like ethnicity, family history, if it is there, certain things, as I said, when during after menopause, these are non-modifiable risks. You can't change that. The history is important. But the things which you can change are serum lipid levels. If the cholesterol levels, we see, the LDL levels should be within normal limit. The hypertension, that is high blood pressure, should be taken care of. We should ask the patients to have decrease the or even stop using tobacco, chewing, or even smoking. Lifestyle should be certain like that it shouldn't be sedentary. People should walk around, exercise a bit. Obesity needs to can be modified. No, we can ask the treat them that by diet control, exercise, we can decrease the body weight. Diabetes is very easily modifiable. We can control diabetes without treatment and definitely certain diets. Next. So what are the signs and symptoms of chest pain? Is it can be a heaviness. Usually the chest pain, most likely the cardiac cause chest pain are very heaviness, feeling of heaviness, that compressive chest pain we say, there is something, a pressure on the heart. Or it can be sometimes burning, aching, and squeezing sort of chest pain also. So we need to ask what type of chest pain you are having. The palpitations, the heartbeat can be increasing, it can be decreasing, it can be irregular. Then the patient can himself or herself say that my heartbeat is irregular or something. That is called palpitation. Exertional dyspnea. Dyspnea is something that is shortness of breath. Breathlessness occurs after a certain exertion like heavy work or walking or exercise. Diaphoresis means increased sweating, because in most cases of myocardial infarction, you see the patients have sweating because of increased sympathetic overdrive, and nausea and vomiting also accompanies. Next. So in the setting of acute coronary syndrome, chest pain is frequently described as a pressure type sensation, as I said, a heaviness sort of feeling, and it can occur even at rest or with minimal exertion. Ischemic chest pain can have radiation. The pain can move down the arms, particularly the left arm, left shoulder, to the neck or jaw, and is commonly associated with diaphoresis, dyspnea, as I said, nausea. Even certain times for inferior infarctions, we get the abdominal pain, and sometimes the blood pressure fall can lead to syncope. Even the arrhythmias can lead to syncope. Next. Importantly, new onset or increased exertional dyspnea, that is, it was not there previously, is the most common anginal equivalent and is sometimes the only symptom in these particular cases. Next. The fear with feeling of impending doom. The patient can feel that something abnormal has happened, I may die. There is something I need a medical help immediately, because that is very important. The feeling of impending doom is another psychological feature. Next. So older age, male sex, positive family history of coronary artery disease, presence of diabetes, kidney disease, prior history of heart attacks, or history of prior coronary revascularization, with a presence of peripheral vascular disease like the things like claudication while walking, the pain in the legs. All these are high risk factors that increases the suspicion that chest pain is caused by acute coronary syndrome. Next. So the nurses must recognize also the atypical symptoms. So what are the atypical symptoms? That is, which is not the common ones as I described. There can be an epigastric pain in the abdomen, indigestion. It can be a different sort of chest pain. And very important, the atypical presentations occur mainly in female patients, older patients of more than 75 years of age, and those with chronic kidney disease, diabetes, or even those with dementia, the chronic neurological patients. They have certain atypical symptoms which you should not ignore. Next. So diagnosis is mainly based on the presenting symptoms, as I said. now discuss the ECG, as I mentioned, and the laboratory test results like serial cardiac biomarker values like CPKMB, troponin T, or I. Sometimes the patient comes with ECG changes which are not diagnostic. We need to admit the patient, follow it up with serial ECG and serial biomarkers also. So that is the time when we should decide that we can't tell that, oh, you are suffering from gas or acidity, you go home and later you get some damage. It is very bad for the patient because we don't want to lose anyone whom we couldn't diagnose. So best is to admit and follow it up. Next. The description of the presenting symptoms and the history of previous illness is very important. And the family history, I am again telling, is quite important to diagnose. Next. These are the certain ECG changes. Next. The ECG provides information that assists in diagnosing acute MI. It should be obtained as early as possible, at least within 10 minutes when the patient reports a chest pain. We shouldn't delay. We should refer the patient to a place where they can get medical in the form of emergency care in any hospital or nursing home in our neighborhood. Next. So, as I said, in ST elevation MI, usually the ST changes show that its peak upright or inverted TA is very important, and the ST elevation is important. And when there is a Q wave has developed in the ECG, that means there is a long time has passed, and the Q wave development shows that the area is having prolonged ischemic changes that is leading to necrosis. Next. The CPK-MB is one of the very important enzyme. As I said, it elevates within 4 to 8 hours and it peaks in 12 to 20 hours. But very importantly, it returns to normal after 48 to 72 hours. So early, the CPK-MB rises within 4 to 8 hours and normalizes within 48 to 72 hours. Similarly, LDH also does the same thing, but it has a delayed return to normal. Next. Next. The troponins I and the troponin T levels are elevated at 4 to 6 hours. It peaks at 14 to 18 hours and usually return to baseline over 6 to 7 days. These enzymes have increased specificity for necrosis and therefore very useful in diagnosing the MI, because in certain cases with the CPK-MB can be raised due to some post-operative cases or skeletal trauma, but TROP-T and TROP-I are have a better specificity to indicate necrosis. Next. Myoglobin is another molecule which usually increases. Next. The ABG is quite important because we need to know the pulse oximetry, the saturation is going down, SpO2 is going down, then ABGs might help us. The WBC count also increases usually on the second day. Next one. The second day, next one. The WBC count may increase, and WBC count is not only, it's an inflammatory process. It not only increases due to infection. So we should not think that we need higher antibiotics from the beginning because the counts are raised. In these cases, the count, if it is increasing, it usually increases after the second day. And the ESR also increases on the second or third day after MI. The inflammatory response is there. Next. We should always send the electrolytes, including the renal function test and liver function test, because when there is changes in sodium and potassium level, it can alter the specificity, the conduction, and compromise the contractility. Next. The lipid profile, that is the total lipids, LDL, HDL, VLDL, total cholesterol, triglyceride, and phospholipids are quite important. And elevations may reflect atherosclerosis as a cause for coronary narrowing or spasm. So these atherosclerosis, arteriosclerosis occurs due to the abnormal lipid profiles. Next. So echocardiogram is very important because echocardiography should be done to determine the dimensions of chambers, the septal and ventricular wall motion, the ejection fraction, the valve configuration and function. So echocardiography says whether there is a regional wall motion abnormality. If there is a wall motion is abnormal, then that particular wall has been infarcted. So the ventricular wall motion abnormality is quite important. And the ejection fraction, usually in these cases, when the heart contracts because of the acute myocardial infarction, the ejection fraction goes down and the patient goes into heart failure. So all this can be noted with any good echocardiography. Next. Chest X-ray is not urgent, but this is very important because if there is heart failure or if there is a long-standing cardiac disease, that can show an enlarged cardiac shadow if there is a heart failure. And also there can be the pulmonary edema can be visible like bat wing pattern or something on X-ray. Then the pulmonary edema, which is a very important thing in heart failure. Next. And finally, the most important thing is coronary angiography. That it visualizes whether the coronary arteries are blocked or not. And it is usually done in conjunction with measurement of the chamber pressures and assessment of the left ventricular ejection fraction. Next. And even in the same sitting, when the primary PCI can be done, a stent can be put into the culprit vessel and the blockage can be opened. So that is very important. So coronary angiography, diagnosis, and finally the treatment can also be done immediately. So the goal of medical management is to minimize the myocardial damage, preserve the myocardial function, and prevent the complications. Next. So then, very importantly, the treatment is very important. Morphine, if the patient is in heart failure, it decreases the chest pain and the discomfort. The oxygen is very important because there is an imbalance between the oxygen supply to the heart. Nitroglycerin, if the blood pressure is permitting, we can rule out a right ventricular infarction, then nitroglycerin or the nitrates can be given because to relieve the symptoms, sorbitrate tablet can be given under the tongue if the chest pain is there. Aspirin should be given immediately. At loading dose is very important. A clopidogrel loading dose is also very important in these patients. If the patient is having from ST elevation MI, if you don't have the facilities for a cardiac intervention, then thrombolysis should be done. Anticoagulants like low molecular weight heparin may be added. And very importantly, the restlessness should be decreased by sedatives. And also the stool softeners are very important because they are given, see in all your prescriptions, the patients are mostly prescribed these medications. But the nurses should know that these sedatives releases the anxiety and the sympathetic drive. Also stool softeners, because if they don't pass stool, if there is constipation, the stool softeners help in relieving the stress also. Next. So thrombolytics are usually administered IV. The purpose of thrombolysis is to dissolve and lyse the thrombus in a coronary artery, allowing blood to flow through the coronary artery again, minimizing the size of the infarction and preserving the ventricular function. Next. The thrombolytics should not be used if the patient is having any bleeding or bleeding disorder. And to be effective, thrombolytics, like earlier days, streptokinase, nowadays we have better thrombolytics. They are administered as early as possible after the onset of symptoms that indicate an acute MI, generally as early as possible within 3 to 6 hours. Next. So what are the contraindications? Because if there is a history of hemorrhagic stroke, means already intracerebral hemorrhage had occurred. If there is an intracerebral tumor which can cause bleeding, if there is any history of active internal bleeding, if the blood pressure is too high, more than 180 or so, if there can be a chance of bleeding, recent head injury, current use of anticoagulants, these are the contraindications where we cannot use thrombolytics like tenecteplase or streptokinase. Next. Analgesic, to reduce the chest pain, morphine is very important. It can be given as IV bolus to reduce the pain and anxiety. And cardiovascular response should be monitored, particularly blood pressure and respiratory rate. Next. So the emergent percutaneous coronary intervention usually, if the facilities are there, because nowadays in most facilities, the facilities are there, PTCA or even if needed, coronary artery bypass grafting can be done. Next. So the nursing management for a patient with acute MI is to achieve a balance between the myocardial oxygen supply and demand, which are achieved by oxygen administration and medication, and also to prevent complications. We need to continuously monitor the cardiac functions with continuous ECG monitoring, hemodynamic monitoring, Monitoring and recording the intake and the urine output is very important, because in these patients, if there is symptoms of heart failure, we need to have a negative balance. Next. You should closely monitor and prevent complications associated with MI, particularly dysrhythmia and cardiogenic shock, and provide emotional and psychological support that is continuous process, explain and provide adequate information and knowledge about disease condition and treatment process. Next. So, very important, the nursing management is very critical. It should be systematic, and the efficiency is needed to implement the care of a patient with myocardial infarction. That's the point we're discussing today. Next. So the duty of the nurse is to also to assess for chest pain not relieved by chest or medication, monitor the vital signs, which you always do. That is checking the blood pressure, noting the pulse rate. If abnormality, you have to report to immediate senior and also to the doctors in the ICU. You have to assess or presence the importance of shortness of breath in the form of increasing respiratory rate, shortness of breath, or chest freckles. And also, if there is nausea and vomiting, you have to take care. Next. And the urine output, if it is decreasing, very important. And precise and complete physical assessment to detect the complications. You have to assess the IV sites. If a patient has been thrombolized, the blood has been thinned, and there is chance of bleeding also. So the IV site should be checked regularly. Next. So the relief of pain is most important, because the patient needs that, and there should be less myocardial damage if we can do it promptly, and we have to reduce the anxiety also, thereby maintaining the adequate tissue perfusion, which is most important. The blood supply, which has been compromised, should be relieved. Next. So there should be absence or early detection of complication. The chest pain should be controlled, or even after adequate treatment, the chest pain disappears, the heart rate and rhythm normalizes, which shows that there is cardiac tissue perfusion has been normalized, and we need to sustain that. An achievement of activity level sufficient for basic self-care is the need of the day. Next. So a plan in place should be also there to meet the needs even after discharge, when the disease process and treatment plan has been such that the prognosis is understood, the patient is improving. We need to plan the need for discharge. Next. Next. So general priorities for patients are hemodynamic monitoring, close observation of the vital signs, a review of the fluid status, which can provide information whether the kidney perfusion is normal, as some patients may present or develop heart failure during or even before treatment. Next. Next. Blood glucose monitoring is quite important in these patients. Even stress-induced hyperglycemia can occur. And if the patient is diabetic, we should use insulin in such a way that the blood glucose level should be less than 180 or so. So a patient with more than 200 should be treated immediately. And the ICU protocols are there, how you need to control diabetes, because blood sugar levels should be normal during the whole treatment plan. The patients recently diagnosed with diabetes should be referred to a diabetes specialist. Next. So symptom monitoring is very important, because we have already prescribed nitroglycerin or morphine, and serial ECGs also you should look into the monitors, whether arrhythmias are occurring or not. Patients who are considered high risk should be managed where continuous cardiac monitoring is available, because they are at high risk of arrhythmias, which can precede a cardiac arrest, which we are trying to prevent. No, thank you. Next one. And we know, as I am repeatedly saying, the patients are likely to be anxious and frightened, and the patients are at intermediate risk, maybe managed at medical assessment unit. Nurses caring for patients should have the ECG interpretation skills, even if you don't need to have the big things like other specific ones, like abnormal ones, but the basics of the STT changes, the arrhythmias, the heart rate irregularities, irregular rhythm, all these you should be able to monitor in the ECG monitor and in regular ECGs, which you need to perform regularly during the treatment. Next. So, as I said, if there are any wounds or dressings, if there are CVP lines, if there are urinary catheters, if there are IV cannulas are always there, the ongoing management, it should be checked regularly. Next. Next. The nurses should be calm and reassuring and ensure pain and other symptoms are well controlled, because you play a central role in providing also the psychosocial support. They should give patients a chance to speak about their experiences, address their concerns, and relay their concerns to the multidisciplinary team in your hospital. Next. So nursing care for patients who recently had coronary angiography should monitor radial and femoral access sites, because there can be complications regarding the radial site or the femoral access sites who have already had coronary angiography. So keeping clear and comprehensive notes is crucial too, because the clinical status and the areas of concerns are in your hands. You need to report that to your seniors. Next. So close communication with the cardiac catheterization unit and the coronary critical care unit is crucial. Nurses receiving these patients needs clear information about the type of procedure they had, any complications, medications, and IV fluids. And very importantly, that is whether the medications have been used, which has put them into greater risk of bleeding. So communication between the cardiac cath lab and the coronary critical care unit is quite important. Next. The development of chest pain specialists and acute coronary syndrome specialist nurse, those has improved care of ACS patients, particularly those with non-ST elevation MI. These nurses can perform acute triage assessments, facilitate early access to specialist services and cardiologists. Next. As I said, the priorities are to relieve the pain and anxiety, to reduce the myocardial workload, to prevent and detect, assist in treatment of life-threatening dysrhythmias or complications, and promote cardiac health and self-care. Next. So, and also we need to encourage changing of positions frequently to keep fluid from pooling to the base of the lungs, because there is pulmonary edema. Change of position is quite important, because, and most importantly, these patients, unless there is a severe drop in blood pressure, you need to encourage bed rest with back rest elevated, because 30 to 45-degree elevation is important. If the patient is lying flat on his back or her back, that the chest discomfort and this shortness of breath might increase. Next. Next. As we all know, the temperature and other vitals should be done in regular basis, like you do for all patients. And the urinary output, changes in skin color, and the laboratory values should be tracked regularly as and when they arrive, and you have to report it to the doctors. Next. So after implementation of the intervention within the time specified, you need to look whether adequate tissue perfusion is maintained. It can be seen by the relief of symptoms. The anxiety usually decreases and the urine output is not compromised. Next. So the ongoing assessment is quite important, like airway, breathing, circulation, and vital signs, cardiac monitoring, rhythm analysis, laboratory studies, and the medications should be titrated as and when ordered, because as the patient improves, usually the titration is done. And as the patient improves, the medication dosage come down from IV to oral, and subsequently discharge occurs. Next. So the most important thing at the last part of my talk is the complications. These are dysrhythmias, means arrhythmias, which the most common after an MI in 80% of MI cases. The ventricular tachycardia, ventricular fibrillation are the most dreaded ones. Acute pulmonary edema, sudden heart failure leading to shortness of breath, cardiogenic shock when the BP goes down, it's not increasing. There can be a tear or the dysfunction of the papillary muscles inside the heart, and there can be collection of fluid in the outside the myocardium, and the pericarditis occurs, and sometimes the fluid is such that it compresses on the heart and it can cause cardiac tamponade. In certain cases of right ventricular infarction, usually due to the right coronary artery circulation, the right ventricular elevated height despite relatively normal left ventricular filling pressure resulting in decreased cardiac output. And the next one. I'm reading the next one. And it also has a high mortality rate. And next one, ma'am. Next slide. In these patients, when there is right ventricular infarction, these patients up in the thing which is opposite to the normal things which you do for any myocardial infarction patient. In these patients with right ventricular infarction, we have to avoid nitroglycerin and nitrates. And in these patients, to increase the blood pressure, they may need IV fluids also. So this is the description of the treating doctor. Next. So the signs and symptoms like weakness, fatigue, shortness of breath, dry hacking cough, being frothy. Sometimes they have left-sided heart failure, the LVF, we say, left ventricular failure. Being frothy, sputum comes out for these critically ill patients because of the pulmonary edema. Next. These things we should always monitor in conjunction with your ICU team. Next. Next. Then the right-sided heart failure is something which causes backup of blood into the right atrium and venous circulation. And it usually occurs with symptoms of increase in the neck vein pressure and also the edema occurs. Next. So here also the fatigue, anxiety, dependent bilateral edema, the legs get swollen and the nausea and weight gain occurs. Next. So all these signs should be monitored for a heart failure patient, particularly, as I said, the distended neck vein and peripheral edema in the legs. And if the patient is lying down because the patient is on bed, then we have to look for the sacral area behind the back whether fluid is accumulating or not. Next. So the diagnosis in these cases to look for either heart failure, we use NT-proBNP, and NT-proBNP is one of the markers. If it is increased, it is usually a sign of heart failure. And echocardiography, as I mentioned, shows whether the ejection fraction is decreasing or not. Next. In these patients also, they need oxygen, IV access, diuretics. We give the furosemide infusion also in these patients. We try to increase the urinary output. We try to keep a negative balance, but because of that, there can be sodium and potassium loss. So we need to monitor the blood sodium and potassium level to prevent and treat hyponatremia and hypokalemia. Next. So these diuretics are most important, and when the blood pressure falls, we need to give inotropic support in the form of dobutamine or even vasopressor supports in certain cases with noradrenaline. Next. As I said, pulmonary edema is the acute life-threatening event when the lung alveoli become filled with fluid, serosanguinous fluid, and that leads to pink frothy sputum coming out. Most common cause of pulmonary edema is left-sided heart failure. Next. So in cardiogenic pulmonary edema, the inadequate left ventricular pumping causing increased fluid pressure, as I said, the fluid fills the alveolar space in the lungs, and it is caused by heart failure, and mainly as the point we are discussing today, acute coronary syndrome. Next. Now, these are the signs and symptoms of pulmonary edema as I described. Next. Treatment. Even certain patients, they need intubation and ventilatory support because we need to improve the oxygenation. Bronchodilators are sometimes prescribed, but diuretics and medications like vasopressors and the inotropes are very importantly needed. Next. Next. Other complications other than heart failure are myocardial rupture and aneurysmal dilatation. These are very risky. Even ventricular septal defect can occur. Mitral regurgitation, cardiac arrhythmias, acute pericarditis are the most important complications of myocardial infarction. Next. 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 Sometimes the infarcted myocardium becomes so weak that it cannot tolerate the pressure inside the chamber. This may lead to rupture of the free wall of the left ventricle or even aneurysmal dilatation. The rupture is usually an early catastrophic and very fatal event. Usually patients with myocardial rupture need to be recognized early, otherwise quite fatal. Ventricular aneurysm impairs cardiac output because the paradoxical motion of its wall. Double diffuse or displaced apical impulse is noted on physical examination. These are very rare complications. Next. As I said, the infarcted septum may perforate and leads to ventricular septal defect. It is common in elderly and hypertensive patients. And very importantly, it needs emergency surgical repair. Next. Next. Myocardial regurgitation can also occur early in the course of MI. If there is rupture of the papillary muscles, emergency surgery should also be taken in these cases. Next. The cardiac arrhythmias, as I mentioned, ventricular tachycardia and ventricular fibrillation are the most common cause of death after MI within the first 24 hours. Hemodynamically unstable VT and VF should be treated with DC shock, and hemodynamically should be stable VT could be treated with IB beta blockers and other molecules which helps in reducing the anti-arrhythmogenic medications. And atrial fibrillation is common after MI and can be treated with beta blockers. Amiodarone can be used to prevent the recurrence. Next. Bradyarrhythmia. When the heart rate decreases, it can occur due to sinus node dysfunction and conduction disturbances. The AV block may occur during acute MI, especially in this case of inferior wall MI. In these cases, they may need a temporary pacemaker immediately. At the ICU itself, we need to administer atropine immediately and try for a temporary pacemaker. Usually they recover, otherwise sometimes permanent pacemaker is also needed. Next. Acute pericarditis is one of the very important symptoms where it develops even 2 to 10 weeks after MI, and it is called Dressler syndrome, which is an immune-mediated disease. The treatment is aspirin the patient is already on, even NSAIDs might be needed, but this is usually occurs 2 to 10 weeks after an acute MI. So these things we should keep in mind. Next. So the ongoing assessment after all discussion are the basics of ABC, the vital signs, the oxygenation, the serial ECG, urine output, and mental status. Next. And finally, the cardiac rehabilitation should be thought of because the long-term program that involves periodic evaluation, certain exercises, education, and counseling about the cardiac risk factors and modification prior to discharge. Next. So smoking cessation, increase in the physical activity, reduction in body weight, reduction in the daily salt intake, control of hypertension and diabetes, lipid management, improving the exercise tolerance, and symptom control, psychological well-being, and stress management are most important. Thank you for your patient hearing. I conclude my talk here.
Dr. Pritam Sen.
Thank you, Dr. Sen, for your brief discussion.
Thank you, sir.
It was a very good discussion. Acute coronary syndrome is a very common problem which we encounter. And whenever the patient comes, it's the nurses who initially assess and gets the ECG done, and then the doctors come, and then we divide into non-ST, ST, and then the process starts. So nurse play a very crucial role in the initial management of MI.
Right. So this is the reason we are discussing today, and if we can update, it's good. Thank you, sir.
Thank you.
Sir, please ask attendees if they have any questions. So write down in the chat box.
Okay, attendees, do you have any question in the top regarding this topic? The participants,
Right.
kindly ask question if you have anything.
In the chat box, there is no question as much I can see.
That's the same thing.
Okay.
Okay, then I think we can conclude the session.
Thank you, sir. And thank you, ISCCM nursing program, because I feel it will help the nurses to evaluate and be better prepared for treating the patients. Thank you, sir. Thank you, the ISCCM. And
Okay, thank